Next, I'd like to introduce Professor Jen Morton, talking on identifying therapeutic opportunities for biliary cancer in GEM models.
Thank you. Thanks for the organisers for the invitation to speak here. First, a disclosure, because I work on pancreatic cancer, so a lot of this is accidental work. But we followed up because we think we've created some interesting models to study cholangiocarcinoma. So I guess when we started this work, when we made these accidental models, we looked back in the literature to look at the modelling, the in vivo modelling of cholangiocarcinoma, and realised that actually a lot of the models out there are quite flawed. A lot of them are in vitro models, and I'm very much an in vivo modeler. A lot of them involve transplants or other agents to induce disease, whereas the GEM models allow you to track from pre-invasive lesions right through to invasive cholangiocarcinoma. And there have been several GEM models described, and obviously Ed described a very nice one with inflammation, but other models have had issues, co-occurrence of other diseases, for example. So we started, because we work on pancreatic ductal adenocarcinoma, and those models are also quite flawed, we started trying to create duct-specific pancreatic models, and I'm just telling you this so you understand what we actually did and why we did it. So the pancreatic ductal models, or the pancreatic models, are quite flawed, and we wanted to create a more refined model, just targeting the duct cells. So how we did that was to use ductal CREs, so either a cytokeratin 19-driven CRE-ER or a SOX9-driven CRE-ER, both which should allow targeting to the duct epithelium. Pancreatic cancer is almost always KRAS mutation-driven, so we picked that as our first hit. And we'd previously shown that P10 deletion dramatically accelerated KRAS-driven cancers, as you can see here. So we basically combined KRAS and P10 mostly as a proof of concept. Those tumours appeared to be of ductal origin. So yeah, this was a proof of concept to get the most rapid model that we could, or so we thought. So I'll just introduce this model briefly first, which is the SOX9-driven model. We have mutation of KRAS, specifically within the duct. We have P10 loss, and we also have a tomato allele to track recombined tumour cells. And we induce these mice about 6 weeks old and then just track them to the endpoint. And we can, again, like Ed, use our RFP marker, and you can see we get nice recombination in the bottom panels, in the liver and in the bile duct. We also do get some cells within the pancreas, none in the lung. And so when we follow these models up, we can see that KRAS activation and P10 loss actually drives cholangiocarcinoma formation really nicely. So you can just see from the H&Es, we get nice cholangiocarcinoma. This is extrahepatic. You can follow that up with ultrasound imaging really nicely, and you can see, hopefully, on the ultrasound imaging, the thickening of the bile duct. You can see the nicely recombined cells, so both again in the liver, intrahepatic, and in the bile duct, also in the pancreas, but not in the lung. But actually, when you look at the prevalence of pathologies in our homozygous mice, we get 100% incidence of tumours in the bile duct and in the liver. We do get pancreatic as well, but that's not what they die from. So this is deaths due to cholangiocarcinoma specifically. And you can see it's actually a really rapid model. Even the heterozygotes are pretty rapid, but the homozygotes is a very rapid model. And we see liver dysfunction and a lot of the blood markers that are seen in the clinic. When we talk to our cholangiocarcinoma pathology friends, well, they told us to do these stains, so we did. And you can see both the extrahepatic and intrahepatic in the P10 heterozygotes and the P10 homozygotes. And we get really nice induction of tumours that express the markers that we would commonly see in the patients. So the extrahepatic or perihillar CCA looks a lot like human CCA, and the intrahepatic cholangio looks a lot like human small duct CCA. Unsurprisingly, probably, these tumours also express markers of KRAS and PI3 kinase activity, given that these are the driving lesions. So we see high levels of phospho-ERK, which is downstream of KRAS, and high levels of phospho-mTOR and phospho-AKT, which are downstream of PI3 kinase, which is upregulated following P10 loss. And importantly, I guess, low P10 or high AKT or mTOR activity correlates with poor prognosis in the patients. So we wanted to know if we could target them preclinically. This is actually pancreatic data because I wanted to introduce these drugs and why we thought they might be effective. So we have inhibitors from AstraZeneca, a MEK inhibitor and an mTOR inhibitor, which should target pathways downstream of both KRAS and PI3 kinase. And I should say that pancreatic cancer is just as hard to treat as cholangiocarcinoma. And we've never cured a mouse, but this was the first time that we ever saw tumour regressions. So we were quite encouraged by these data. Although obviously you can see that we don't see any cure. This is our preclinical testing pipeline. So what we do is we ultrasound the mice to confirm they have a tumour prior to enrolment on trial, and then we image them weekly to follow tumour progression or regression. And you can see actually nicely here, this is a dilated bile duct with a tumour growing inside it. So these are the data from our SOX9 KRAS P10 model, treating from when we can detect a tumour by ultrasound. And you can see, well, you can see first that they come down pretty rapidly. So we have vehicle-treated mice here, and you can see just with standard chemotherapy, either cisplatin or gemcitabine, or both cisplatin and gemcitabine. There's really not a massive extension in survival, except in one outlier mouse. Whereas when we use our targeted therapies, aside from a couple of unlucky mice, we had pretty impressive extensions of survival. The mechanism for this is unclear, or the mechanism for the resistance is unclear, I guess, because we have looked at cell death and cell proliferation, and the cell death is actually fairly modest, and there's no effect on proliferation. So then we wanted to look and see do other models recapitulate these findings. So I mentioned earlier that we tried to make these models of pancreatic cancer in the duct, and another one was driven by CK19, like EDS. But again, on this model, we used KRAS and P10 loss. And these mice also get cholangiocarcinoma before they get anything else. This is a less useful model to work with because they do also get lung cancer. But all the P10 homozygous mice die from cholangio, And you can see again that we have both intra and extrahepatic tumours. Again, you can see duct thickening, and you can see markers of liver dysfunction increase. This is a breakdown of where we see tumours in these mice, but again, they all die from cholangiocarcinoma. And again, just to validate the model, we did the staining that's commonly done in the clinic. And again, these mice look a lot like, or the tumours in the mice, obviously the mice don't look like people, the tumours in the mice look like human cholangiocarcinoma, both intrahepatic and extrahepatic. And the perihilar tumours, again, look like the human disease. Like Ed's model, I guess, and this is something that we don't understand, why the CK19 and the SOX9 drive different pathologies within the liver, but within the liver we get intrahepatic cholangiocarcinoma. With intrahepatic large duct cholangiocarcinoma. They recapitulate human cholangiocarcinoma at transcriptional level. So you can just see here on a UMAP the human versus the mouse, and they're there in the black, sitting in between pancreas and liver, which I always like because anatomically that's where they sit. But you can see that the mouse and the human overlap quite closely. And again, they express the markers of activated KRAS and PI3 kinase activity, like our SOX9 model. So again, we did the same treatment experiments in these mice. Again, we found that the survival untreated mice is ridiculously short. Standard of care chemotherapies have negligible benefit, but our targeted therapy is actually pretty impressive in terms of survival. And all of these censored mice died of something other than cholangiocarcinoma. So they were effectively cured. And differently from the CK19 model, we don't see a lot of effects on cell death, but with our targeted therapy combination, we do see quite significant reductions in proliferation in the tumours. So in this model, we looked a bit more closely at resistance mechanisms, and we see that phospho-ERK activity downstream of KRAS or downstream of MEK is still significantly reduced at endpoint. Signaling downstream of mTORC1 is still significantly reduced at endpoint. Interestingly, we see phospho-AKT, which is downstream of mTORC2, reactivated in extrahepatic tumours, but not in intrahepatic tumours. So there appears to be different resistance mechanisms in those two tumour types. And this, I'm just going to show you another pancreas slide, because this is different from what we see in pancreas, where we actually see reactivation of signalling in the fibroblasts. But we haven't seen that so far in cholangiocarcinoma. So obviously the next question that we want to ask, and we haven't done it yet, is there hope for KRAS inhibition in these tumour types? So I can show you some pancreatic data which says, yes, there probably is, because these mice are impossible to cure, and we're getting really extended survivals with the KRAS inhibitors. And we've done this with KRAS G12D inhibitors, but also the pan-RAS inhibitor. And you can see really nice responses in these mice. And I guess for the early detection and intervention setting, again, this is pancreas, but we can actually clear preneoplastic lesions with these inhibitors, just putting the mice on treatment before there's frank tumorigenesis, and we can pretty much clean up all the preneoplastic lesions. And just lastly, second lastly, We think this is quite encouraging because there is a subset of cholangiocarcinoma patients in which these therapies might be effective. And with regard to the KRAS inhibitors, just to say that KRAS G12C also is very effective at driving cholangiocarcinoma. So those inhibitors are further forward, so there may be a place for them. So just to summarise, I hope I've shown you that SOX9 cell-specific KRAS activation and PTEN deletion can drive cholangiocarcinoma that recapitulates human extrahepatic and small duct intrahepatic cholangio. CK19 cell-specific activation also drives cholangio, but with a different phenotype, at least intrahepatic. And the tumours are transcriptionally similar to human CCA. Standard of care therapies have very little efficacy in this setting. However, targeted therapies significantly prolong survival, although we do see resistance. And we think understanding these resistance mechanisms might be important, obviously, in this setting, but also in the setting of novel mutant KRAS inhibitors. So with that, I'd like to thank, I wouldn't call them, well, I'll call them Team Pancreas and Cholangio. Most of this work was actually done by this guy here, Curtis Rink. But I'd like to thank the whole team and the bioinformatics and the services at the Beatson, without whom we couldn't do any of the in vivo work. And is that time for me to shut up? Guido, a very helpful pathologist in Rome, and Simon Barry, AstraZeneca. And with that, I guess I'm not taking questions.
At the end.
Am I coming over there?
Yeah. See.